Hello, the topic is Green Top Guideline number 20A, External Cephalic Version and Reducing the Incidence of Term Breech Presentation 2017. Women should be informed that the success rate of ECV is approximately 50%. A woman should be informed that after an unsuccessful ECV attempt at 36 weeks of gestation or later, only a few babies presenting by the breech will spontaneously turn to cephalic presentation. Women should be informed that few babies revert to breech after successful ECV. Women should be informed that a successful ECV reduces the chance of caesarean section. Women should be informed that labor after ECV is associated with a slightly increased rate of caesarean section and instrumental delivery when compared with spontaneous cephalic presentation. ECV success can be predicted to some extent, but the use of models to predict success should not be used routinely to determine whether ECV can be attempted. Use of tocolysis with beta mimetics improves the success rate of ECV. Routine use of regional analgesia or neuraxial blockage is not recommended, but may be considered for a repeat attempt or for women unable to tolerate ECV without analgesia. ECV should be offered at term from 36 weeks of gestation. Women should be informed that success rate of ECV is approximately. In nulliparous women, ECV may be offered from 36 weeks of gestation. There is no journal consensus the eligibility for or contraindication to ECV. Women should be informed that ECV after one caesarean delivery appears to have no greater risk than with an unscarred uterus. Women should be counseled that with appropriate precautions, ECV has a very low complication rate. ECV should be performed where facilities for monitoring and surgical delivery are available. The standard pre-operative preparations for caesarean section are not recommended for women undergoing ECV. Following ECV, EFM is recommended. Women undergoing ECV who are D negative should undergo testing for fetal-maternal hemorrhage and can be offered anti-D. ECV should only be performed by a trained practitioner or by a trainee working under direct supervision. Although most women tolerate ECV, they should be informed that ECV can be a painful procedure. The uptake of ECV is best increased by timely identification of the baby presenting by the breech and provision of evidence-based information. There is no evidence to support any particular service model, although larger institutions may consider a dedicated ECV clinic. Women may wish to consider the use of moxibustion for breech presentation at 33 to 35 weeks of gestation under the guidance of a trained practitioner. Women should be advised that there is no evidence that postural management alone promotes spontaneous version to cephalic presentation.